safely in the home. So we have invited one of our special people, Dr. Eleonore Paunovich, who we all call Ellie. Ellie is assistant professor in dental diagnostic science. She also is a graduate of our special geriatric fellowship in geriatric dentistry, and now is a teacher in the geriatric dentistry program here at the Health Science Center and the VA, and also works with geriatric dentistry at our VA hospital treating older veterans, and did a special research project in the home on oral health needs and what is being done or not being done in the homes throughout our area. So we've asked her to share some of her research, some of her findings and information about the dental needs of the homebound elderly. So please welcome Dr. Paunovich.
Gee, thank you. I think I'll do this again. That was nice. I'm real happy to be with you this morning here and share with you some of the thoughts and findings and some of the frustrations that many of us in the dental community have. Probably frustrations from what I gathered from the previous hour that a lot of healthcare providers and all of us in the room have when it comes to getting reimbursement for services that we provide for not necessarily only the elderly patients, but more specifically institutionalized or our homebound elderly patients. Dentistry probably suffers the most in the sense that we're not included in any Medicare reimbursements except for some extractions of teeth, but routine oral health care and oral health maintenance is totally non-existent in any type of reimbursement plan. And as you'll see within this next hour, all of you being in the healthcare profession, I'm sure have realized that oral health has a very, very strong component in overall patients' health, and it appears that it's even more significant with the aging population, and I'll express some of those thoughts in a little bit. One of my concerns has been the fact that we have this big wave, as someone expressed earlier, of elderly patients coming into the realm of needing services that we provide as healthcare providers. The numbers are really staggering. Something like 6.7 million people right now in this country are homebound elderly. That is, that they are not capable of going out. They have some functional limitations. If it's 6.7 million today, what's that number going to be like now come the year 2000? That's what startles me. We're not able to manage all of the health care needs of that population now, of our population now, so we really need to start getting aggressive. And I'm learning now that the only thing to do is become a political activist. I may have to set aside my white coat a little bit in providing treatment and really start, and I think a lot of us are going to have to start doing that, lobbying our Senates and our House and our legislatures that are involved in funding. And I'm going to get off that soapbox because we're talking about oral health today. In the over 85 group, functional limitations are usually the limitations that set the homebound population homebound. And 60% of this population reports some limitation in their daily activities. And if the statistics go as projected, the 6.7 million will double within the next 20 years. And we really need to be prepared for really a different demand than we've had with our conventional medical and dental problems that we've seen. Some of the concerns, why is oral health important? Well, for those of us who, even within my own profession, some dentists may not, we really don't train dental students to realize the implication of poor oral health if we become medically compromised, emotionally compromised. We really emphasize managing the oral health needs of a relatively healthy population. And our curriculums in our dental school are changing to meet the needs that we have now in our society, and that is that we're beginning to get a population that's living longer, and it's living longer, but it also has many more chronic medical problems that may have been managed over a very long span, 20, 30 years. and the associated physical debilitations that come with some of these chronic problems. Medications have done wonders to keep people living. Medicine's made some wonderful advancements in surgical procedures that cure people that maybe, 20, 30 years ago may not have survived beyond the age of 60, 65. And so we really have to begin teaching our students a whole new concept of not only managing well patients, but managing what I call medically compromised individuals, and not only medically compromised, but mentally compromised. That's probably the biggest burden I think that we've encountered. The oral health, and I'm assuming that you all will follow this real quickly with me. If we look at overall quality of life of our patient population, we basically find that as we age, we have our aging physiology, and we get into this area of disease comorbidity of dealing with all of the disease processes. But revolving around this normal aging physiology are aspects that many of us with tunnel vision will treat the problem that we identify as our specialty, but we don't treat that problem in the realm of the whole patient context. And this is what this model is trying to indicate, that we have a social aspect to the patient, and in my case, I may wonder why a patient presents with social isolation. If they're capable of going out, if there's someone who's willing to take them out to the mall, they can't get out there themselves, but to go out and see some people, or go out to a restaurant, or go to a son or daughter's home. Why is it that they don't want to go out? They feel okay, they don't have any aches or pains. There may be an aesthetic problem. They may be embarrassed by the way they look, their teeth. And this is a common complaint that I come across in a lot of the nursing homes that I visited, is that the patients are concerned about how they look. They may feel that their mouth looks bad. They may be concerned about bad breath. And they may feel that it's almost a disfiguring feeling that they have. There's an affective function and a cognitive function. Some of them may not have those totally. And then we have our physical limitations. And those all go into our impairments that lead into frailty or disability concepts. Well, this is your traditional medical model of quality of life and treatment of the patient as a whole patient. What I have gone ahead with some of my colleagues is propose what we call the oral health quality of life model, because we're finding that as our population ages, certain things that we took for granted really become important. And it involves bringing in not only the physical, but the oral function and oral health status of that patient, and bringing it into that diagram that we saw earlier. The reasoning behind that is that if you encounter many of your patients, how many of them will complain about the fact that they don't have teeth to eat? Some of us who provide nursing care to the patients and medical care to the patients may get concerned about the fact that they have lost a lot of weight. And weight loss becomes a problem in maintaining the patient at certain levels, and we get concerned about that. Well, there's a myth that if you don't have teeth, you're not going to eat well. And it's a myth. There are many patients in the community here that we've seen that do not have teeth, haven't had teeth for 20 or 30 years, and yet it hasn't affected their intake of food. But there are a few who, without teeth, they don't enjoy food. And that's the critical part, is food enjoyment. Think of what's really important now. With us, as busy as we are with our homes, our careers, and families, there are a lot of other priorities that take over. But I'm sure everybody in this room does enjoy going out to eat. They wouldn't have all these restaurants in San Antonio if we didn't like to go out to eat. And it's not just a matter of convenience, because they'd all be basically the same. They've got every type of food to tempt your palate. It's how food tastes. You have enjoyment. It's a social arrangement. It's not just nutrition. A lot of us will meet friends for dinner, meet family for dinner. That may be the only time you socialize with friends or family, is at dinner time. Imagine sitting at a table and having food that tastes bland, has no taste. You can't really appreciate the taste, or it has a bad taste to you. And it's not bad because it's the way it's cooked, it's because your taste buds have changed. This all fits into the realm of oral health. People who have poor oral hygiene will ultimately develop changes in their taste buds, because where are the taste buds located? On the tongue. And what happens when we have poor oral hygiene, but you get accumulation of debris, the sloughing of the epithelium as it turns over on the tongue. And medications are another big change in taste. A lot of our cardiovascular medications will produce metallic taste, side effects, if they're used in doses that are not really geriatric dose for patients. They're what we call the toxic dose or the side effect. And those changes in taste are, we've seen, and they're in the literature, are enough to actually change what may be a sweet and sour taste into a very bitter taste. And so those are some of the considerations that we have, not necessarily on dentition. When I came into the fellowship, I came from being a general dentist for about 12 years and treating relatively healthy people. I was in the Air Force, and I always seemed to be stationed at the retirement meccas. I was at Patrick Air Force Base. I was here in San Antonio, where we have a large retiree population. And it was really funny, but many of the dentists that I worked with were afraid to treat elderly patients that were sick or had a list of medications that, you know, was more than 2 drugs. And I had no fear of that. I felt actually more comfortable because, to me, my geriatric patients are always much more appreciative of the services I provide for them than some of my younger, healthier patients were. And so I just kind of went into geriatrics by default. I was the only one that was wanting to do that. And I really enjoyed it, but I saw some demands on our population that weren't being addressed by our profession or our healthcare profession in general. And that's what we're going to address today. The specific aim of the study was to assess the oral health needs of the homebound population. But more specifically, what I was trying to do was also find or develop this model where I could correlate various other factors that had to do with cognition or their affect or their physical impairment, and see that if a person, for instance, has a stroke and has been rehabilitated to a certain extent where they can function with one hand, to what extent are we going to have to really provide oral health care, direct oral health care? How much will that individual be able to do themselves? If they've got a cognitive problem, to what extent can I rely on that patient to take care of their own oral health? And when do I, as a healthcare provider, have to make sure that there's a plan in place to help augment that oral health care? Now, why are we so concerned about oral health and oral hygiene? If we look in the literature, there are people who have died from oral infections, especially when we get into these fail immunocompromised individuals. Those that have had COPD or emphysema long-term, have been on long-term steroid use. They're very prone to fungal infections. They're very prone to bacterial infections. And what is one of the best sources in the body for fungi and bacteria but the oral cavity? It's an avenue for septicemias, for brain abscesses. This has been documented, and I think as we get more and more elderly in institutions where oral health care is neglected, you're going to see that being reported even more so. So we were trying to establish if we could correlate some of the medical problems and needs assessments, and we're developing that model now with our data to really find out what can we do to intercede and try to prevent problems. I always hear about the problems when they're acute, you know, when there's pain or swelling. And I think that if we get on the road of trying to be more preventive and establish oral health care programs for not only institutionalized but for the homebound patients, that will really be making some major strides in our healthcare system. Unfortunately, if you look in the literature, there's very little, if any, data on the homebound population in general. And so what I was trying to do is get a handle on what does this population look like and what are some of their demographic features. Now, the assessments that we did were not only dental, and this is in developing this model of being able to correlate some of the functional and cognitive and affective limitations. We looked at vision, and we screened vision using the handheld Rosenbaum card. We did a hearing test and used an audioscope with that. We did a test for depression and used the geriatric depression scale to assess their affect. We did the mini mental state exam, another really quick way to assess their cognitive. Now, these aren't very elaborate tests, but they're giving us a handle as to where we've got potential problems. We also did another type of cognitive and affective test, which is the executive interview. And I'm not really going to talk about those results. We were basically trying to compare and contrast number 4 and 5 here to see if one would give us more information than the other did.
Just as a reminder, they were given the whole scheme and the geriatric depression scale this morning.
Okay, so you've got that already in your handout, and that's exactly what we use. Additional assessments were the physical self-maintenance scale. It's easy for me as a healthcare provider to say, you've got to brush your teeth. But what if you can't really hold that toothbrush? Or what if tomorrow morning when you get up in the morning, you just go and have breakfast and totally forget that brushing your teeth is part of your normal wake-up regimen? So these are clues that I can have that can modify a treatment plan or a program for you specifically, and not just assume that because you fall into a category of, for instance, a patient that's had a stroke, that all stroke patients have to be treated equally. This is what I see happening a lot of times, is that we think we try to generalize a category instead of customize that treatment. We did a nutrition survey, and this is where we had the poorest results because it was a survey that we left with the home to be filled out. You don't do that. It doesn't work. They never come back in the mail. But the idea here was to actually see what types of food they ate, what consistency the food had, and see if they were actually getting, you know, a good balanced meal, because a lot of nutritional problems can be manifest in the oral cavity before any other problems are noticed. And I'll touch upon those in a little bit. Masticatory assessment, we were actually trying to see what their chewing efficiency was like. We had to drop that because we were using carrots for them to chew. And a lot of this population, we had potential aspiration problems, so we had to stop that. And then we also wanted to find out how many problems they were being managed for and what type of medications they were taking. And what I'll present to you is just an overview of all of that data. The oral health assessments that we did were basically a comprehensive exam that you would have if you go into your dental office today. We did a complete soft tissue exam. We looked at all of their teeth that they had them, looked at their periodontal, their soft tissue bone support to see how their gums were doing, looked for tooth decay. We looked to see what condition the teeth they had were in as far as their fillings or crowns. And then if they had dentures or partial dentures, we wanted to take a look at what those looked like also. And the final thing that we did was an oral hygiene assessment, which was actually looking to see how clean their mouth was. And this is, you'll find, is the biggest problem, is just keeping their mouths clean. And that's the root of all the other problems. You know that when you go to your dentist or your hygienist, it's you've been missing your back teeth, you've got to brush more, you've got to floss more. Well, it's a different story with the population that we looked at the home. The grip strength, one of the things that I've been advocating, and it's very common sense, and you'll probably sit there and you'll go, that makes sense, but it's not done out in the real world. Back to the stroke patient wanting to brush their teeth. How many patients, it doesn't matter if you've got stroke, arthritis, something that really doesn't incapacitate somebody severely, but enough to affect their activities of daily living. How many people will look at, they won't brush their teeth, well, they'll brush their teeth and they'll come and they'll say, well, I brushed my teeth, but it doesn't look like the toothbrush hit their teeth or their gums. Well, the problem is that they may take the toothbrush, they may go through the act of brushing their teeth, but they're not effectively brushing their teeth because they don't have that grip. And so you have to then assess, well, what is their grip? They have to have their toothbrush modified. So what we've been doing now, and we do this with all of our patients that we work with over at the extended care now at the VA, we do a grip strength test, and we have them grab one finger. And if they can grab my one finger, that means they can hold that toothbrush pretty well. So then something else is a problem, either coordination or whatever. The other thing is that when you do the grip strength, you've got to do it with their hand by their mouth, because your grip strength can differ with an extended hand out to you as opposed to that hand coming up to where the patient would, because different muscles are being used and there may be some atrophy in those muscles. If they can't grab with one finger, then they're not getting a good grip on their toothbrush, so we have to modify their toothbrush. And there's been, in many of the nursing homes, I see nurses providing, or nurses' aides providing oral hygiene care in patients that could do it themselves, but they just don't have that grip for their brush. And today, if you look at the market, it's not just modifying a toothbrush, but they have all sorts of electric toothbrushes that are designed for people like this, and the prices have come down significantly. You can get the Oral-B people now have them for like $29.95, where you can buy the battery-operated electric toothbrush that has a good grip on it, and the patient can actually help themselves, and then maybe require a nurse or a nurse's aide to come in maybe once a day, just to make sure that all the surfaces have been taken care of. So the grip strength and modifying a toothbrush can be as easy. It doesn't require any fancy, you can go to Eckerd's or Dillard's, and they'll have these little cuffs that you can put on your toothbrush, but they'll run about $3 or $4. You can go to Builder's Square or Home Depot and buy insulation that they use on water tubing, and buy, for $3, you could buy about 20 feet of that stuff and just cut it to fit the toothbrush handle and slip it over the toothbrush handle. So it's an easy way to help that individual develop some, and they feel good when they can take care of themselves. I see the frustration that my patients have when someone has to take care of them. They don't want to wait for one. Okay, they don't want to wait to be shaved. They don't want to wait to have their teeth brushed. They want to go out on the porch to smoke their cigarettes, so they get really upset with us, if we're not on time to help them with their needs. They get really frustrated. At the VA, you can tell that I work with a predominantly male population, so the cigarette smoking, they built this fancy smoke room for those of you who work at the VA downstairs in the basement. It's just amazing that they'll keep that door open and that smoke will just get sucked up right into that whole area in the basement. They can't stop it. It's just a behavior we can't stop. What I did is I went out and spent a summer visiting the entire homebound, hospital-based homebound patients that were in the VA program 2 years ago. And what we did is we went to all of the homes, and all of the assessments that I showed you are what we did. We found out this is predominantly a male population again, so some of this data may reflect a little differently if we start to add females in the database itself. But what we found out that the average age of these patients was about 75 years of age. We had a couple of young gentlemen that were in their early 40s, and those individuals were veterans who were, one was a cab driver and was shot and had brain damage as a result of the shooting, and then there was a muscular dystrophy patient in that group also. And the rest, you could see from 54 up to 103. And it was interesting to note that, this 103 individual had so much more going for him. I mean, I couldn't keep up with him. I mean, it's amazing. You think that by the time you get up there, he put some of these younger guys to shame. He really had, I think, good genetic characteristics, just that his eyesight was failing and a few other problems. The majority, though, are in this latter 60s, 70s age category. And I think that if you look at the trends in other home-based programs, this is very true to what the trend is for this home-based population. They're going to be an average of around 75 with a range of somewhere from about 65 to 75. Now that probably will start moving up a little bit more as we get more numbers in the population. What were these people being managed for? And this is a beautiful picture because if you look at the data on institutionalized elderly, this is very similar to the problems that we see with the institutionalized. So home care patients aren't necessarily less sick or less functionally capable than many of the institutionalized individuals, which is one of the things that we found out in this particular population. The predominant problem were CVAs, and that goes across the board. I think if you look at our institutionalized patients, the majority of them are in there for some type of cerebral vascular accident. Cardiac complications were right underneath with cardiac, and that included coronary artery disease, peripheral vascular disease, and that whole wash angina, and then hypertension. Diabetes was a large proportion also. Again, This is probably a very demographic to this part of the country. If we look at national statistics, diabetes wasn't necessarily that high on the national statistics that we looked at. Dementia was also another common problem, and it was interesting. It was really a humbling experience. I had never been involved in making home visits. You know, in dental school, as a dentist and being in practice, my patients always came to wherever I was practicing. But to go to some of these homes and to see how some of these people with very little financial support or resources make a go of it is truly, truly a humbling experience, as it makes all your problems so insignificant. It really is an eye-opener. Visual problems, aphasia, which tied in with the CVAs, congestive heart failure patients, and then we had some of our arthritic patients that had degenerative joint disease, and a few of the other problems, carcinoma. This brings in the point of why oral health screenings are so important for this population. 5% of the head and neck cancers that are in the population occur in those that are 70 years old and older. Even if they don't have any teeth, doesn't mean that they're not going to be prone to running the risk for oral cancer, especially if there's a history of smoking and drinking in their background. They have a very high risk, and those numbers are going higher. Some of the others here that we saw but weren't significant enough, just to give you an overview of the type, we had a thalassemia patient. Iron deficiency I didn't really list, but it was a common problem amongst a good proportion of that population. Nutritional deficiencies, the B12, the iron, the vitamin K, a very common problem. And if it wasn't for programs like Meals on Wheels and some of these church groups that actually try to bring well-balanced meals to the homes, the diets reflected that they really weren't getting their minimum daily requirements of food intake. So the range of problems ran an average of 7 problems per patient that they were being managed for, anywhere from 3 to 13 per patient. And the number of medications they were taking, and this was an eye-opener also, when I asked about medications, invariably the caregiver would take me to their bathroom and open up a medicine cabinet, or they had on the top of the commode a little box, and this was real common, where they had maybe 25 or 30 bottles of prescriptions. There were prescriptions that were sitting there that were as old as 10 years, sitting on these commodes, as old as 10 years. But it was for ache or pain or something they treated me, and I wanted to keep it just in case I needed it. You know, so these are some, and I think that I see a lot of heads going, this is a real common problem. There's no management, and I think this needs to be part. The nurses that I went out to are working very actively on developing a home pharmacotherapy, you know, cleaning up that medicine chest. The doctor would go in and he would make the house visit and he'd clean it out. And he said, if you've got a problem, you call me and I will give you the prescription. I think that will take care of a lot of the problems. In dealing with geriatrics in the last few years, I found out that a lot of times when I have assumed that I have had a possibly demented patient or a confused patient, it wasn't that they were really demented. It was a side effect of something as simple as taking 3 Advil tablets because I've got an arthritic pain in my back. If you look, taking 600 milligrams of Advil and taking it every 4 hours for someone who's 72 years old, has peripheral vascular disease, one of the side effects is confusion, disorientation. So I wonder how many times we've labeled these patients without running some actual assessments to say, yeah, they really are, or no, it's a side effect of the drugs they're taking. Over-the-counter medications, a big problem. They had, and then the other problem that I noticed here that I hadn't before are the herbal remedies and the little packets that they get when they go to Mexico. You know, there's a little envelope that you take this tea for indigestion or what. And again, we don't know how some of those may interact with some of the stronger medications that they do take for angina or that they do take for some of their other medical problems. So those were some of the things that we found. Very interesting, an average of 6 medications per wonderful because if you've got a question about the meds, they can actually analyze the medications for you, give you an idea of any potential interactions that you may have. And that really, I think, has helped a lot of us who do prescribe medications keep this to a minimum. How depressed was this population? Amazing. Very different from institutionalized patients. When we ran the geriatric depression score, the mean was about 4, which meant that they as I mentioned, as the patients that I've seen in a lot of the nursing homes, but there was either a family member or a caregiver that was contracted to help manage that patient. And I think being in your home surroundings has a lot to say for your overall outlook and psychosocial perspective, if it's possible. How cognitive were they? Well, this group, this is where it differs a little bit. When we went to the lowest range on our cognitive was 9, and we went up as far as 29 out of a possible 30. We had a few people that were definitely Alzheimer's patients, and it was amazing on the ones that were up in the areas of 28, 29, how their spouses, in both cases the spouses were taking care of the patient, were insistent, no matter how difficult the management was, I had them at home, and I can take better care of them at home than if I have them in a healthcare facility. And they were very adamant about not having that loved one moved, but they were having to have locks on the doors, and one house had 6 locks on it because he had figured out how to, he'd figure out how to open one, and then he'd go wandering, and so a neighbor would bring him back, and then they had to put another lock. And if you looked at the door, the locks just kept on going higher and higher, like having a little kid at home again. They were relatively cognitively functioning at a very, very good level, very normal level. So they weren't, as an overall group, very cognitively deficit. Physical function, this is what I was really concerned about. How did they take care of themselves? What we were looking at was a physical self-maintenance scale where you assess their capability to do their toileting, feeding, dressing, grooming, physical ambulation, and bathing. How well are they at taking care of themselves? If we give a point to each of these items in these groups, we would have a maximum score of about 30, was it 30? Yeah, of about 30. And you can see that the mean was about 14.6, which meant that they needed assistance in more than one area. The common areas that they needed assistance were in the dressing and in the grooming. A lot of them had the physical limitations of not being able to use their hands, side effect of the strokes. Physical ambulation was another common problem. And then it was amazing to see the work that the home-based nurses had done in providing toileting and bathing care. The bathrooms had been fitted with aids to help the individual with stools in the shower, handheld shower heads for some individuals. There were a lot of modifications in their bathrooms that really enabled these people to work still on themselves a little bit, which was a nice feature. Okay, now we get to the oral health. This is where it really gets dismal. Of this population, one of the myths that we have is that as you grow old, you're going to get like grandma and grandpa. You won't have teeth, you'll have dentures. That's changing. Dentistry has done some wonderful things with preventing tooth loss, and more we're finding individuals today that are in their 70s. I just had a 72-year-old gentleman in the clinic yesterday that had all of his natural teeth in and only one filling, which was just remarkable. I wouldn't have found that, I guarantee you, 20 years ago in this population. The trend today is that because of all the advances in dentistry, people are keeping their teeth longer. They may have some missing teeth, but they're not all missing. So not all patients are going to have dentures that you have as we get older, either in an institution or in the home. What we're also finding out, though, is that their care is almost non-existent. It's the last thing that we think of, besides all their other health needs. So when we look at with the patients that had teeth, 53% of them have teeth, 47% didn't have teeth. If you look at the statistics of about 10 years back, about 70% of the population in this age group had no teeth. So you could see that that number has really changed significantly, and we're probably going to see that more so. Of the edentulous patients, the ones that didn't have teeth, there were 63% of them had dentures, and 37% didn't have dentures. And when we look at how long these people had been with dentures, the age range was anywhere from 8 to 75 years, and the average life of one denture was about 22 years. Which, if you look at the average life of a denture, normally it's between 14, 15 years, somewhere in that aspect. So we saw a lot of dentures that people were hanging on to that really didn't fit well, they were broken, but they kept them because that was their only teeth that they had, and they didn't have the finances or the resources to go ahead and get new teeth. If you, some of the problems that we saw, a lot of them had irritations that were associated with loose dentures or ill-fitting dentures. A lot of them, most of them were loose. They would just, and I'm sure that some of you have seen some of your patients, they'll talk and their dentures will just flip down, they'll fall out of their mouth. They need to be at least relined, if not replaced. A lot of them were broken, and it was amazing how ingenious these people would get. A lot of them would, well, with the loose dentures, I came across a couple who took toilet paper, stuffed it into the denture and wet it, and then they'd push it up in their mouth because they knew that that toilet paper would conform to their jaw, and it actually helped. It did the trick for a while and helped keep that denture up more, you know, because they couldn't afford to buy adhesives or the paste or the powders. You know, because there's other medications that have to be bought, food and paying the home payments, the utilities and all. Candidiasis is the fungal infection that we see in the mouth, and that we see a lot of times in people who have been sick for a long time or on a long-term steroid therapy, like your emphysema patient, the COPD patients. And the candidiasis was a problem. It's not a painful problem. It's an irritation of the soft tissue that is underneath the denture area. The problem, though, is that it's a fungal infection that's taken over. It's a normal fungus in the mouth. But when the immune system gets a little tilted, if they've been sick, had the flu, had a cold, something like that, that fungus may actually start to predominate in the mouth. And if it goes unchecked and there are other problems with infections or abscesses in the mouth, it's an avenue where you can actually have cerebral abscesses as a result of a fungal infection. And so that's not a very common problem, but it can become a problem in this type of population. Of the patients that had teeth, on an average, the individuals had about 20 teeth per patient. You can see that they range from anywhere. There were people with only 2 teeth in their mouth, up to all 32 teeth. They had, the interesting thing to look at here was that of the teeth that had fillings, there was only an average of about 2 teeth per individual that had fillings. This population, instead, when they have a filling or a cavity that they need or a tooth decay, many times rather than going and having it filled, it's a lot cheaper to go to some of these clinics to have it pulled. And what we're doing is because of a matter of resources and finances and convenience for that individual, because they may be homebound and not able to have someone come to their house to fill a teeth, but they may actually be able to have someone come to their house to pull a tooth or go to the office down the street where it's cheaper to pull a tooth than to fill a tooth today. So you end up having a lot of our aging population having teeth pulled that could be actually saved. And there's nothing better than keeping your own teeth. No matter how hard we try to make good dentures and good partial dentures, there's still this adjustment phase of trying to learn to live with them. And when you're in your 70s and 80s and you've got problems with your breathing, you've got pains, you can't walk too far, you can't walk at all, worrying about some of these things really is not as important. We didn't find too much tooth decay because those that did have cavities ultimately had them pulled. And so it's amazing that the resources to pull teeth, the avenues were a lot more, I mean, that seemed to be the mindset. I've got a problem with the tooth, it's going to get pulled. I'm not going to try to fix it. And this is where we really get into some amazing scores. When we looked at their plaque scores to see how clean their mouth was, the average plaque score was 98.5% of their tooth surfaces in their mouth had plaque. And all of you who go to your dentist know that's a no-no. You know, I mean, and what's the problem with plaque? It causes generalized gingivitis, inflammation of the gums, and that could create some pain. It can create discomfort. It can lead to abscesses and infections and periodontal disease. These people, some of them had not seen a dentist. The average time of not having seen a dentist was 15 years for this population. It went as high as a gentleman who was 103 years old. He had teeth in his mouth still. He was keeping them very clean, but he had not had his mouth checked for 28 years. And think of the oral cancers again and those kind of things that can be a problem. When we looked at grip strength, remember what the physical self-maintenance scale was on the population? It was they needed some assistance. With grip strength, if you look at only 23% of the population had no grip at all, which meant that they were the stroke patients that were aphasic, they were in bed, not able to do anything for themselves. The ones that were able to grasp the toothbrush with one finger was only 16%. That left the rest of the population needing some type of modification or not being able to grip at all. And that's a problem when it comes to home care, oral hygiene, because now we're adding another portion into the picture. If you yourself cannot maintain your own oral hygiene, like any of the other physical self-maintenance scales, you require a caregiver to help you with those activities. How many caregivers are trained in oral hygiene care? It's not an existing program for homebound patients. We have in-services in nursing home facilities for oral hygiene that we teach the nurses and all, but there are no programs that I know of where we actually have either dentists or dental hygienists. A dental hygienist is probably one of the areas that's most underutilized that could be of the best help to help improve these problems, where maybe a family can consult with the dentist that they go to, their dental hygienist that they go to actually get the modified care that they need. How do I brush the teeth on my mother who's an Alzheimer's patient who won't open up, who'll bite my fingers? That's a common problem. And when they have these cognitive deficits or dementia, organic brain disease, they actually may not be able to get in the mouth of the patient because they may lose their fingers, you know, if they do try that. So finding the proper mouth props to get in there. This is the source of all potential problem, is that oral hygiene. And if we can start to develop programs that provide in-service training to the nurses who go out to the homes to help them educate the caregivers, or actually involve the dental member. You know, now OBRA mandates that a dentist does evaluate a patient's mouth. I think that should carry over into homebound programs also, because to me that population isn't any different than the institutionalized. The only difference is that instead of having an institution taking care of that individual, now it's a independent caregiver or some of these home health care services. So I think augmenting some of these home health care programs, if any of you are involved with them, I think trying to integrate some type of oral health care plan where dentists, now where do you find dentists? This is the other problem. And it's very difficult. I was reading a chapter last night in oral health care delivery. Dentistry today is very sophisticated. Our GEC unit operates with a portable dental unit. We do have the capacity, not only us, but the dental community has the capacity, we have the equipment to actually load up a dental unit into our cars and go to a home. We have that capability of providing the dental care that you get in a dental office in a home environment. But what are some of the problems? Well, we don't get paid for the time and travel. Well, first of all, you hardly can get the money to pay for the procedure itself when you go out there. Then you have the time and travel, loading up, the total weight of these units is probably about 140, 150 pounds. It breaks down into 3 independent little units. So, breaking up your units, taking your equipment, setting it up in the car, driving, and then setting it up in the house maybe takes another 20 minutes to half an hour perhaps. There is no cost allotments for that. These are just some of the problems. Now here through the GEC and through our geriatric program, we have gone out in the community. There are dentists in the community who do homebound dentistry. Calling the local dental society is one way of getting a hold of who those individuals are. Talking to dentists that you maybe go to yourself and finding out if they may be able to see the patient. Many times arranging, VIA now has a transportation system where they can pick up some of these patients and bring them to a dental office. It's not necessarily anymore that they may not have the transportation from home, the capability, but with VIA and some of these other services, they may now have that capability. These bring in a lot of questions and thoughts. For food, we've got the technology, we've got the capability, but like everything else, it's the money. And remember one of my opening remarks was that I think it's time to take the white coats off and start going up to Austin and start talking to politicians. Start a grassroots level phenomenon here within the city. Some of the things that I didn't realize were people like United Way, some of these campaigns, they actually can provide some of the fees for these services. So it requires some research into looking at avenues of where you can possibly get funding. So that's where I leave you. I know you probably have some questions. No? Yes, ma'am.